Since we met last year, I've been spending a lot of time thinking about our industry, how it's growing, and it is growing, and what particularly is the role that I and my team can play during this phase, really, of unprecedented growth in connected health. Now, just for fun, reminisce with me for a minute, and I'll take you back to, or perhaps I won't because I can't get the slides to advance. There we go. This is going to be fun. So this is the mid-90s, and someone said to me this morning, "Joe, you don't age." Here's proof that I do. This is me, circa 1995. And at that time, I was really in a career transition and had this crazy idea, what I didn't think it was crazy, others did, that we could do care in a time and place independent manner. And to be honest with you, it was kind of fun to be amongst the oddballs at that time. It was, we sometimes thought we were on the lunatic fringe, we weren't sure. There were a handful of people around the planet that were really thinking this way, and there was some comfort in that. Now, if you look at the technologies, God, it's a wonder we got anything done, right? Look at what we had to work with. And one of my, if you allow me to reminisce for a minute, two of my particular favorites, one is the VTEL device on the top left. Any of you who were around then remember we had this thing called ISDN. Every one of these things had to have 3 separate phone lines wired into it so that we could get enough bandwidth to do a jerky video conference. $60,000 for the device, and I don't remember how much for the 3 lines per month, but it was amazingly expensive and not very good, and like I said, it's a wonder anyone bought into any of it. And then my personal favorite is the Kodak DCS-420, which is the bottom middle, and that's a camera that I got acquainted with. That's how I got into this space. We were testing the validity of digital images in dermatology, and I used that device, which cost $12,000 and took less than 1 megapixel images. Again, lucky we got anywhere, and lucky that we held on to the vision. So fast forward, every day now, most of us video conference with colleagues, friends, loved ones using mobile devices. That camera that I worked with, well, you know, it's long gone now. It's 12, 15 megapixels in your smartphone, the camera, the computer, the network, all in one device, and we can do amazing things. And in dermatology, swapping images around now is something we don't even think about. We have come a long way. And our industry itself is growing rapidly. Now, in 2013, we're about 2.4 billion overall, but look at the growth projected in 2018. $21.5 billion it's going to be. So you couldn't argue with me that this is a growing industry now. It's a vibrant, growing marketplace. That's why so many of you are here. That's why we have so many new exhibitors. That's why there's such a vibrant energy around innovation in this space. Lots and lots and lots of promise. Now, back here at Partners Health, we're not standing still. We have programs that are robust and all over our system. This is an example of an MGH program run by my colleague and friend Lee Schwam and another friend, Sarah Sosong, who's the director. They've done amazing work with virtual video visits. Likewise, over at the Brigham and Women's Hospital, there's a growing interest in program in this regard, led by another friend, Adam LaCursey. So lots going on at our academic medical centers in using virtual visits to reach out to our patients and follow up. Then there's acute care telemedicine. Telestroke now reaches, believe it or not, 65 million citizens of New England who previously did not have access to a stroke neurologist can get one using this technology if they show up in the emergency room with symptoms of a stroke. If you just stop and pause and think about what a lift in quality of care that is, it's pretty amazing. This is mainstreaming, and of course, other academic centers around the country offering similar services. We're not alone here. Online second opinion, I don't know of an academic center around the country that doesn't offer some sort of online second opinion service. This is ours. We launched in 2001. We continue to run it, and our team that does a fabulous job overseeing this continues to work with patients all over the world. MGH is working with Grand Rounds. Grand Rounds is here. If you want to learn more about them, they're doing a satellite session. You can learn more about their organization. Brigham, Dana-Farber, everyone's in the business now of online second opinions, something that when we started this in 2001, we got some quizzical looks because people were using the web browser then as a tool to show brochures, not to do real work. If you look at the remote monitoring side, once again, this is a program, Connected Cardiac Care, that was started over 10 years ago with collaboration with our team at Connected Health and Partners Healthcare at Home, our home care group, and is now in their hands, implemented by them in collaboration with our population health team for patients with congestive heart failure, a routine offering. So that's something that we grew and cuddled and brought off and sent off and is now a vibrant, growing program. Right behind it, and this one is still in that land between pilot and scale, and I'm going to come back to that challenge of getting things from pilot to scale in a minute, but this is Diabetes Connect, Blood Pressure Connect. Again, these are programs we're doing with our pop health team, and they're in the hands of our patient-centered medical home practices and growing. So I ask myself when I look at all this, what's left to do? Some days I do. And of course, there's a lot left to do. Now, I'm a big fan of this adage, leadership is about knowing when to intervene. Someone taught me that about 10 years ago, and I've loved it ever since because you can get a lot done if things are just happening and you don't need to be part of it. You can get a lot done by focusing your energy where intervention is required, right? And so where is intervention required at this point, or is it? Is it possible that all of this is just going to spread like wildfire, and I can maybe retire, maybe virtually, with my smoking jacket? Now, I don't smoke, but again, I've got virtual reality headset on, so I could at least contemplate a future where I don't have to do anything, and this all just happens. So that's a fleeting thought. And honestly, if you look at my favorite metric of all this, any day that I'm feeling particularly like we really conquered the world, my favorite metric is the percent of actual virtual care that happens compared to the percent of care delivered overall. And it's still, it's a fraction, let's face it, a fraction of a percent probably. So yes, there's more to do. Now, as I've, again, been contemplating this for several months, last few weeks, I've had 3 experiences that really helped me frame where I think we should be focusing energy collectively and where I and my team can add some value. And I want to spend the rest of my time talking to you about these 3 themes. So the first has to do with some patient/consumer challenges. Now, a few weeks ago, I had the opportunity to join this gentleman. His name is Dan Ray. He does late night AM talk radio on WBZ here in Boston. I had never really participated in that kind of a venue before, and so it was a really new experience for me. And I found it to be really interesting, and I cherished it. And thankfully, he's invited me back because I really, really did appreciate getting a viewpoint from a different lens, and that's really what this was about. We sat for an hour, about 10 o'clock at night. We talked about connected health, and then we took calls. And I really came away with 2 insights from those calls, and when you think about it, people who listen to and call into late night AM talk radio, it's a really different segment, and it's a segment that we don't really get a chance to hear from very often in our world. And the 2 themes that I learned, well, one was people still think this is pretty futuristic, right? What about my doctor hasn't talked to me about it? I don't really know. I'm not going to do this thing unless my doctor wants to do it. There's a lot of that kind of talk. So that's interesting, and I have something to say about doctors in a minute. But the other one that came through loud and clear was this fear of privacy and security. And it's I really, when I think back to the Target data breach and all that's happened since, we really weren't prepared for this. And there's recent chatter around on the internet that you can hack into wearables and so forth. We've got to really fix this as an industry, and we got to fix it in a way that doesn't just add a lot of cost, right? There's companies around that will be happy to do a more secure offering for you at a much higher cost, because after all, it's medicine, and we're used to paying a lot of money for things that are medical grade. We need a different strategy. We need a different strategy, and we have to fix this. So we're really excited to dig in and try to move the conversation to a group of people that we haven't moved it to before, that are these leery or not, maybe they're not educated, they're individuals who just haven't been able to get on board yet at the patient consumer level. And we'll do many things, but one of them that we're really excited to announce today is that we're going to work on a second book. I've been so pleased with the response to the Internet of Healthy Things. People tell me it's readable, people are reading it, they're coming up to me constantly and offering us positive feedback, and I'm really pleased about that. So of course we're compelled to do something else. And this one is exciting. So along with my former collaborators from my last book, Carol Coleman and Gina Cella, we're bringing on firepower and support from the AARP to do this book. And we're really excited about that. My friend and colleague, Charlotte Yeh, who's here, is going to contribute. Charlotte will also be keynoting this afternoon at the FitMind Challenge. We really think there's an opportunity for us to reframe how technology is used as we grow older. And we're really excited to do that. And we'll have that book ready for you next year when we meet. So look forward to that. Now on the provider side, well, this guy kind of tells you what I'm about to go into. There's a lot of just general tiredness and fatigue in healthcare providers. But I thought I would start with some survey data that the AMA came out with recently. They did a survey of 1,300 MDs. You may have seen this. It made some headlines if you looked for it. Now, of course, the headline that doctors want to do stuff that makes their lives easier, well, no one should be surprised at that. They're human beings. They don't want to do something that adds work, and it makes sense. Their lives are already quite cluttered with things to do. But let me just go through some of the interesting numbers. The first, 80% had concerns about liability. I'm going to come back to that, because I've heard that, and I've always kind of just brushed it aside and said, well, we just have to design our programs differently. We have to tackle this. Now, on the bright side, 45% are actually eager to do something in connected health. That's pretty good. That's almost half. That's almost half. That's a good thing. But when you look at who's actually doing anything, it's only 12%. Maybe 12% is a good number in 2016. I'd like to see it, of course, much higher. And again, as I look at, well, what can we do? Well, there's an opportunity to do something right there. And I had the opportunity, it was interesting, but the same week I was on AM radio, I went to DC and I spoke to the AMA Council on Legislative Affairs, which is a group of about a half a dozen or a dozen docs that advise the AMA on legislative affairs. And I talked to them about connected health, and they too gave me pause for thought, because there was not a lot of warmth and excitement. There was from some, but there was equal worry from some, and they kept coming back to these two problems. One was data overload. What am I going to do with all of these normal readings? All this patient-generated data flowing in, I don't know what to do with it. People are working on that, but we need to collectively bond together to get that right. Other industries have all this complicated data coming in, and they display it in a beautiful dashboard for their executives, and they click on something and they can drill in and see sales data from China or whatever. We get just 1,000 normal blood pressure readings. That's the best we can do right now. We have to do better than that. And we can, and we will. So that's a problem. And then, of course, the liability problem. Now, I had an interesting discussion with one of our attorneys at our malpractice carrier. I don't know if it's probably not something you'd necessarily be aware of, but Harvard teaching hospitals own their malpractice carrier. It's called Crico. And this woman was very engaged and said, I really want to get more involved in this area. She said, yes, when you order home blood pressure monitoring, it's like ordering a lab test, complete blood count, liver function test, urinalysis, which means that yes, you are obligated to look at those numbers. If that person does have a systolic blood pressure of 200 that comes in and you don't see it, yes, that is a problem, which isn't what I wanted to hear. But again, we should be able to work on that. We have software in other industries that flags things for people to pay attention to. We have alert systems. We can reach you on your mobile phone now. This is something else we need to work out. So there are provider adoption issues, and rather than just keep explaining them away, we decided we would launch a provider adoption initiative, which we're going to do. Now, I'd hoped to say which partner we're going to work with. We're looking at a number of internationally known and large physician advocacy groups to work with. Don't have that yet, but in the coming weeks we'll announce a partnership to do this in a very, very meaningful way across the US and beyond. So I'm excited about tackling physician adoption. It's time we did something about that. The last thing I want to talk about then is this idea, and this comes back to home. I think it's quite relevant to the whole industry, but it's something that we noticed at home, which is how do we cross the chasm from pilot to scale? I looked at a list of our programs. I was just reflecting on a list of things we've done that we've innovated over the past 7 to 10 years. And every single one of them really stuttered between that phase where we prove clinical validation and then getting it ready for scale. And frankly, some of them aren't yet ready for scale. And they're just in that, it's a very, very tender phase, it turns out, and I hadn't paid that much attention to it. Others in the industry see this in the world of startups when they get to a certain level, what's required of them to get to scale. So it's a problem that people have been talking about. And the insight that I learned as I reflected on this was really about how clinical research is different than real world. And it's magnified in our area because most connected health interventions are successful because they improve engagement, right? If you keep your consumer or patient engaged, they will do better. We've shown this, others have shown it. And clinical trials are a pretty engaging environment, right? We give people incentives. We have a whole group of people here today in the audience, our research assistants, and they're out constantly making sure we get people in our clinical trials to stay in our trials because we need their data to be able to do some kind of scientific analysis. And then you get those same programs, same products, put them into the real world, and they don't have any of that, or not as much. So, for instance, we learned consumers and patients do not tolerate technology failure. I think it's interesting that people will work to repair their Bluetooth headset, but if the Bluetooth blood pressure cuff stops, they just I don't know, can't do it, it doesn't work, done. One time. We got to do better at that. During clinical trials, believe me, if your technology isn't working, we'll be in touch with you. And we can't scale that, so we have to do better at that. Again, we do all kinds of engaging things and incentives during trials. We've got to figure out how to build some of that stuff into the apps themselves as we get them into the real world. And then on the doctor side, there's a whole different set of concerns about workflow. Well, I want the data displayed in a certain way in the electronic record because I want to see it next to this value, and we're working on that. But there's also the phenomenon, which if any of you are physicians, we've all experienced this, me included when I'm in my practice, which is, oh yes, the person came in who's an ideal candidate for program X, and I just forgot because it wasn't right in front of me on the screen. So lots of opportunities to do better when we get things into the clinical workflow as well. And what we're doing this year is we put a stake in the ground that we are going to do a comprehensive plan and trial it out on how to get from pilot to scale. And we'll be happy to report what we learn as we go along because I'm sure it will take and be a challenge. As we look at how different we need to be in this new world, we need to be more collaborative, we need to be more of a convener, we need to be more involved in our thought leadership. We've invoked a new look, a new mark, and we've tweaked our logo. And as you'll see more and more of this on our materials in the coming years as we integrate it into our website, into our materials, we're really excited to be able to put this new look forth because it gives everyone a sense that indeed we're looking at the world differently. We're trying to be a big tent organization now as all of these efforts around us grow to change connected health. So yes, leadership is required, and no, I'm not retiring. It's all of this opportunity, and I'm excited about our work with AARP. I'm excited about doing this physician engagement initiative, and I'm very excited about our partnership with the PCH Alliance to bring this conference to a whole new level. Back at Partners, we need to be more collaborative, and we're working on a way to do that. One of the groups here today is our new Fellows group. That's an example of a program we're doing. We also have the Chic Challenge tomorrow afternoon. That's another example of a program we're doing to bring people in and be a more collaborative group within Partners Healthcare. So I'm excited to be here today and to be here tomorrow and to be with all of you, and I look forward to meeting you, chatting, learning about what you're doing,